In this video, we'll explore osteomyelitis, covering its lab investigations, imaging, treatment, and complications. In osteomyelitis, basic laboratory investigations play a supportive but important role in diagnosis and follow-up. A complete blood count is done to look for evidence of infection. In acute osteomyelitis, the white blood cell count is often elevated, reflecting an active inflammatory response. However, in chronic osteomyelitis, the count may be normal, so a normal CBC does not rule out the disease. Blood culture is particularly useful in acute hematogenous osteomyelitis. When positive, it helps identify the causative organism and allows antibiotic therapy to be tailored accordingly. However, blood cultures may be negative in chronic cases or if antibiotics have already been started. ESR is a sensitive marker of inflammation and is usually elevated in both acute and chronic osteomyelitis. Although it rises and falls slowly, it is useful for monitoring disease activity over time and assessing response to treatment. CRP is a more acute phase reactant. It rises rapidly in active infection and falls quickly with effective therapy, making it especially valuable for monitoring response to treatment and detecting persistent or recurrent infection. In addition to routine inflammatory markers, newer investigations also have a role in osteomyelitis. Serum procalcitonin is a useful biomarker for bacterial infection. Levels above 0.4 nanograms per milliliter compared to normal values of less than 0.1 nanograms per milliliter strongly suggest bacterial osteomyelitis. It has a reported sensitivity of about 85.2% and specificity of 87.3%, making it helpful in differentiating bacterial infection from non-infectious inflammatory conditions. Procalcitonin levels also tend to decrease with effective antibiotic therapy, so they can be used to monitor treatment response. Real-time PCR is a rapid molecular diagnostic technique that detects bacterial DNA directly from blood or tissue samples. Its main advantage is speed, as it can identify pathogens much earlier than conventional cultures. This is particularly useful in patients who have already received antibiotics, where cultures may be negative. Real-time PCR helps guide early, targeted antibiotic therapy while awaiting definitive culture and sensitivity results. Plain radiograph is the initial investigation but may be normal in early osteomyelitis. Later, it shows periosteal reaction, bone destruction, and sequestrum formation. Bone scan is highly sensitive and detects early disease, but specificity is low as uptake is also seen in trauma and tumors. Ultrasonography is useful for detecting soft tissue involvement, subperiosteal collections, and guiding aspiration, especially in children. MRI is the imaging modality of choice, as it detects early marrow changes and defines the extent of bone and soft tissue involvement. CT scan is best for visualizing cortical bone, sequestra, and chronic changes and is helpful for surgical planning. Plain radiography has a reported sensitivity of approximately 43 to 75% and a specificity of 75 to 83% in the evaluation of osteomyelitis. Although it is relatively insensitive in the early stages, it remains the initial imaging modality because it is widely available, inexpensive, and useful for ruling out other focal causes of symptoms, such as bone tumors, fractures, or traumatic lesions. In acute osteomyelitis, plain radiographs are often normal in the first 7 to 10 days of infection. The earliest radiographic finding may be deep soft tissue swelling adjacent to the affected bone. As the disease progresses, definite bony changes begin to appear, usually 10 to 14 days after onset. These changes include periosteal reaction, cortical bone destruction, osteolytic lesions, and loss of normal trabecular pattern. In more advanced or chronic cases, plain radiographs may demonstrate sequestrum formation, involucrum, and sclerosis, which help in confirming chronic osteomyelitis and in planning further management. Plain radiography has a reported sensitivity of approximately 43 to 75% and a specificity of 75 to 83% in the evaluation of osteomyelitis. Although it is relatively insensitive in the early stages, it remains the initial imaging modality because it is widely available, inexpensive, and useful for ruling out other focal causes of symptoms, such as bone tumors, fractures, or traumatic lesions. In acute osteomyelitis, plain radiographs are often normal in the first 7 to 10 days of infection. The earliest radiographic finding may be deep soft tissue swelling adjacent to the affected bone. As the disease progresses, definite bony changes begin to appear, usually 10 to 14 days after onset. These changes include periosteal reaction, cortical bone destruction, osteolytic lesions, and loss of normal trabecular pattern. In more advanced or chronic cases, plain radiographs may demonstrate sequestrum formation, involucrum, and sclerosis, which help in confirming chronic osteomyelitis and in planning further management. Bone scan using technetium 99M labeled diphosphonate is a highly sensitive imaging modality for osteomyelitis, with a sensitivity of about 89 to 94% and specificity around 94%. It is particularly useful for early detection, often becoming positive within the first few days of infection, even when plain radiographs are normal. The study consists of 3 phases. The first phase, the blood flow or angiographic phase, demonstrates increased perfusion to the affected area due to hyperemia. The second phase, the blood pool or soft tissue phase, shows increased tracer activity in the surrounding soft tissues, reflecting inflammation and edema. The third phase, the delayed or skeletal phase, demonstrates increased uptake in the bone itself due to increased osteoblastic activity. Increased tracer uptake in all 3 phases is characteristic of osteomyelitis and helps differentiate it from non-infectious conditions. Bone scan is particularly indicated when the site of suspected infection is unclear or when there is a need to look for multiple foci of bone involvement, such as in hematogenous osteomyelitis. In acute osteomyelitis, the scan typically shows hot uptake, reflecting increased blood flow and osteoblastic activity at the infected site. Cold uptake may be seen in areas of bone ischemia, which can occur in severe osteomyelitis due to vascular compromise. It is important to note that increased uptake is not specific to infection and may also be seen in conditions such as trauma, bone tumors, and disuse-related bone resorption, which should be considered when interpreting the scan. Ultrasonography is a low-cost, widely available, non-invasive imaging tool that does not expose the patient to radiation, making it especially useful in children. Its main limitations include low specificity and strong dependence on operator skill, which can affect diagnostic accuracy. Key findings in osteomyelitis include subperiosteal abscess formation, thickening or elevation of the periosteum, and changes in the surrounding soft tissues, such as edema or fluid collections. Ultrasound is particularly valuable for early detection of soft tissue involvement and can also be used to guide aspiration or drainage when necessary. Ultrasonography is a low-cost, widely available, non-invasive imaging tool that does not expose the patient to radiation, making it especially useful in children. Its main limitations include low specificity and strong dependence on operator skill, which can affect diagnostic accuracy. Key findings in osteomyelitis include subperiosteal abscess formation, thickening or elevation of the periosteum, and changes in the surrounding soft tissues, such as edema or fluid collections. Ultrasound is particularly valuable for early detection of soft tissue involvement and can also be used to guide aspiration or drainage when necessary. Magnetic resonance imaging, MRI, is the most sensitive and specific imaging modality for osteomyelitis, with reported sensitivity between 88 and 100% and specificity from 75 to 100%. MRI is particularly valuable for early detection, as it can visualize marrow involvement before changes appear on X-ray or CT. It also helps in differentiating infection from malignancy, which is critical when the diagnosis is unclear. Additionally, MRI allows for accurate identification of subperiosteal and soft tissue collections of pus, providing essential information for both medical management and surgical planning. Computed tomography, CT, is widely available and relatively low cost, making it a practical imaging option in many settings. However, CT is less sensitive than MRI for detecting early marrow changes or soft tissue involvement, so is not the first choice in acute osteomyelitis. Its strengths lie in evaluating deep infections, such as those involving the spine or pelvis, where complex anatomy can make assessment challenging. CT is also particularly useful in chronic osteomyelitis for identifying sequestra, cortical destruction, and sclerotic changes, which are important for surgical planning. Aspiration is an important diagnostic procedure in osteomyelitis. It is performed to confirm the presence of a bone or subperiosteal abscess and to identify the specific causative bacteria, which allows for targeted antibiotic therapy. This procedure should be performed as soon as possible, ideally before starting antibiotics, to maximize the likelihood of obtaining a positive culture. Bone aspiration is typically performed using a large-bore trocar needle or an 18 to 20 gauge spinal needle. The preferred site is the metaphyseal region of the affected bone, usually at the point of maximal tenderness, which increases the likelihood of sampling infected tissue. Cultures from bone aspiration are positive in approximately 50 to 85% of cases, providing critical information for targeted antibiotic therapy. The goal of treatment in osteomyelitis is to achieve the permanent elimination of infection without causing long-term complications. Ideally, the approach should be the safest, with the least morbidity and also cost-effective, balancing clinical efficacy with patient safety and healthcare resources. Successful management combines appropriate antibiotic therapy, timely surgical intervention when needed, and careful monitoring for recurrence or complications. Non-surgical management is appropriate for acute osteomyelitis without abscess formation, where antibiotics alone can be effective. Antibiotic therapy should ideally begin after obtaining blood and bone cultures to guide targeted treatment. Antibiotics must be adjusted based on culture and sensitivity results to ensure effectiveness against the specific pathogen involved. Treatment duration is typically at least 3 weeks, but may be extended depending on the patient's response and disease severity. When abscesses or sequestra are present, or if the infection is chronic or refractory to antibiotics alone, surgical intervention may be necessary to drain collections and remove necrotic bone. Throughout treatment, close clinical and laboratory monitoring is essential to confirm infection resolution and prevent recurrence or complications. The decision to convert from intravenous to oral antibiotics depends on a favorable clinical response. This includes the absence of fever and significant improvement in symptoms such as tenderness, limp, malaise, anorexia, and night pain. Laboratory markers also guide this transition, particularly a reduction in C-reactive protein, CRP, levels. During treatment, weekly laboratory tests are recommended to monitor progress and detect potential side effects. These include complete blood count, CBC, erythrocyte sedimentation rate, ESR, CRP, liver enzymes, AST, ALT, and renal function tests. Careful clinical and laboratory monitoring ensures safe and effective antibiotic therapy and helps determine the appropriate timing for switching to oral medication. Surgical treatment is indicated when there is a presence of an abscess within the bone or when the patient fails to respond to appropriate high-dose parenteral antibiotics. The main goals of surgery are to remove purulent material, avascular bone, and non-viable soft tissue, which helps control infection and promote healing. During surgery, bone samples are taken for culture to identify the causative organism and guide further antibiotic therapy. Routine histological examination is also important because some tumors, such as metastatic neuroblastoma and Ewing sarcoma, can mimic infection by appearing similar to pus. This ensures correct diagnosis and appropriate management. It is important to note that irrigation and debridement are not always required in patients with acute osteomyelitis, especially when there is no abscess or necrosis. However, surgical intervention becomes necessary in certain situations, such as the presence of a subperiosteal abscess, evidence of bone necrosis, or direct invasion of the growth plate. In these cases, surgery aims to remove infected and dead tissue to help control the infection and prevent complications. Regardless of surgical or non-surgical management, the duration of antibiotic therapy typically ranges from 4 to 6 weeks to ensure complete eradication of the infection. The fundamental surgical principle in osteomyelitis is to aggressively debride all necrotic bone, including the sequestrum, which serves as a nidus for ongoing infection. At the same time, it is crucial to preserve the viable involucrum, the new bone formed around the sequestrum, as it provides structural support and is essential for healing and bone regeneration. This balance between thorough removal of dead tissue and preservation of healthy bone is key to successful surgical management and recovery. In surgical management of osteomyelitis, soft tissue care is critical. All devitalized and necrotic tissue must be removed through extensive debridement to reduce infection and promote healing. Regarding the bony work, this involves sequestrectomy, removal of necrotic bone, and thorough debridement of infected bone. When hardware is present and infected, removal of implants may be necessary to eradicate infection fully. Dead space management is a key goal after removing infected tissue. The aim is to replace dead bone and scar tissue with well-vascularized tissue to support healing and reduce recurrence. Options for this include vascularized bone grafts to restore structural integrity and blood supply, local tissue flaps or free flaps to fill dead space and enhance soft tissue coverage, antibiotic-impregnated acrylic beads, which deliver high local concentrations of antibiotics directly to the site, vacuum-assisted closure, VC, therapy to promote wound healing and reduce bacterial load. In terms of instrumentation and fixation, choices depend on the location and severity of infection. External fixators are often favored to avoid placing hardware in infected tissue, but internal fixation may be used in select cases. Various surgical fixation techniques include antibiotic-impregnated polymethylmethacrylate, PMMA, intramedullary nails, combining stability with local antibiotic delivery. The Elizarov technique, which uses circular external fixators to allow bone lengthening and stabilization. Use of intramedullary nails with or without external fixation for fracture stabilization. The Masquelet technique, involving staged reconstruction with induced membranes. In severe cases, megaprosthesis may be required for large bone defects or joint replacement. Together, these approaches aim to control infection, restore bone stability, and optimize functional recovery. Complications of osteomyelitis can be significant, especially in children. Physical involvement may lead to growth inhibition, resulting in angular deformities or limb length discrepancies due to disrupted bone growth. In chronic osteomyelitis, long-standing inflammation and scarring can rarely lead to malignant transformation, most commonly squamous cell carcinoma developing in draining sinus tracts. Awareness and early management of these complications are crucial to improving long-term outcomes. Thank you for your time and attention. Please consider liking and subscribing to the channel.